Hi everyone, my name is Dr. Katie Vaughn from the Internal Medicine Program at Beth Israel Deaconess Medical Center in Boston. Today, we are going to learn the basics of ECMO, or extracorporeal membrane oxygenation. There are two types of ECMO, veno-venous, or VV, and veno-arterial, or VA ECMO. We are going to focus on VV ECMO, which is used to support patients in refractory respiratory failure. Our learning objectives for this video include 1. To identify indications and contraindications for VV ECMO, and 2. To understand and identify the basic components and flow of the VV ECMO circuit. In additional videos, we will dive further into physiology, how to optimally manage the ventilator for patients supported on VV ECMO, and common complications and how to troubleshoot them. So let's get started. In basic terms, VV ECMO functions as an artificial lung and is able to perform gas exchange external to the body. The VV ECMO circuit contains a membrane oxygenator which can oxygenate blood and remove carbon dioxide. It also includes a pump that provides about 4 to 6 liters per minute of blood flow, with the goal of oxygenating at least 60% of a patient's native cardiac output. Importantly, VV ECMO provides no direct circulatory support and relies on the patient's normal heart function to circulate oxygenated blood throughout the body. If a patient does not have normal cardiac function, then VA ECMO should be considered instead. VV ECMO is used for patients with severe respiratory failure despite optimal medical management and ventilator support. Invasive mechanical ventilation is often necessary for patients with respiratory failure, but it is well known that this leads to ventilator-induced lung injury, or VILI. The VV ECMO circuit is used when mechanical ventilation alone is inadequate to provide gas exchange, or when the necessary ventilator settings would cause excessive damage to the lungs. VV ECMO provides oxygenation and carbon dioxide clearance and also allows us to minimize VILI, giving the lungs time to rest and heal. The decision to put someone on VV ECMO is complex and should be made with a multidisciplinary team. There are two main indications for VV ECMO: the bridge to recovery or the bridge to lung transplant. The bridge to lung transplant means that we are using ECMO to support a patient and maintain other end organ function while they are awaiting a lung transplant. These patients have advanced lung disease that cannot be fixed, and we are using ECMO to allow them to stay fit and healthy enough for transplant. The bridge to recovery means that we are using ECMO to support the patient while allowing the lungs to rest and heal. The goal is for the lungs to recover and to hopefully wean the patient off of ECMO support. This is the most common use of VV ECMO. VV ECMO is used as a bridge to recovery only in specific circumstances. The most common indication is severe ARDS. Patients with severe ARDS should be treated first with optimal ventilator settings and proven therapies such as prone positioning. VV ECMO should only be considered if they are not responding to these treatments. The indications are based on the 2018 EOLIA trial and are shown here. VV ECMO can also be considered in severe hypercapnic respiratory failure, such as from asthma or COPD, that can't be managed adequately on the ventilator. And finally, VV ECMO can be used when there is mechanical reason to minimize the amount of ventilator support. Examples are patients with persistent pneumothorax from a bronchopleural fistula or recovery from a tracheal surgery. We should also understand that there are some important contraindications of VV ECMO. Some of the strong contraindications include irreversible lung disease in patients that are not transplant candidates, severe or irreversible disease of another organ system that is unlikely to benefit from VV ECMO, such as metastatic cancer, multisystem organ failure, or anoxic brain injury, the inability to receive blood products, or limited vascular access. Some other relative contraindications include advanced age, morbid obesity, mechanical ventilation greater than 7 days, severe coagulopathy or active bleeding, malignancy, or heart failure, in which case VA ECMO should be considered. Placing a patient on VV ECMO is a nuanced decision. Instead of memorizing the lists of indications and contraindications, think of these in the context of the patient. Can the patient's lung recover, and if not, are they listed for transplant? Does any history limit the use of a bypass circuit with large cannulas and anticoagulation? Are the other organs too sick to be supported? So let's review. VV ECMO is an external artificial lung that is capable of providing full respiratory support. It is typically used in patients with refractory respiratory failure. It is most often used as a bridge to recovery to stabilize a patient while the lungs recover, but it is occasionally used as a bridge to lung transplant. The most common indication is ARDS, but all proven therapies should be exhausted prior to considering VV ECMO. There are also some strong contraindications to a VV ECMO that we should consider when determining if this is an appropriate therapy for our patients. Next, I want to explain the VV ECMO circuit, which is illustrated here. In VV ECMO, blood is drained from the systemic venous system, passed through a membrane lung, and returned back to the venous system and right atrium fully oxygenated. The patient's native cardiac function then pumps the blood through the lungs, which are generally contributing very little to gas exchange, and then out to the rest of the body. VV ECMO is most commonly performed with two separate cannulas. In this configuration, blood is drained from a large vein, usually in the leg, and then returned to the right atrium. The venous drainage cannula is typically placed via one of the femoral veins and is inserted into the inferior vena cava. The venous drainage cannula is quite large, typically 25 French or larger, very long, and has an end hole and sometimes multiple side holes that drain blood from the intrahepatic inferior vena cava in order to withdraw blood from the body. The return cannula is inserted through another large vein, usually the right internal jugular vein, and ends in the right atrium. Compared to the venous drainage cannula, the return cannula is smaller, usually 15 to 19 French, shorter, and just has an end hole with no or few side holes. Ideally, the return cannula is directed so that blood flows across the tricuspid valve to then be circulated through the lungs and out to the body. Single cannula configurations are also used. For this configuration, a special dual lumen cannula is placed via the right internal jugular vein and extends all the way from the superior vena cava through the right atrium and to the inferior vena cava. One of the lumens allows for deoxygenated blood to be drained from the SVC and IVC. The other lumen acts as the return cannula, with the blood flow directed across the tricuspid valve. This type of cannula generally needs to be placed with image guidance so that the drainage and return holes are positioned correctly. The venous drainage cannula is connected to a centrifugal continuous flow pump which creates negative pressure or suction on the venous cannula to pull the blood out of the body. The pump then pushes blood out from its outlet with a high positive pressure and through the oxygenator. As the deoxygenated or blue blood passes through the membrane oxygenator, it gets oxygenated and carbon dioxide is removed. Just like with a mechanical ventilator, we can control the oxygenation and ventilation through the oxygenator. We can set the fraction of delivered oxygen, which we refer to as the FDO2. The FDO2 is typically set at 100% initially, think of 100% FiO2 on the ventilator, but can be reduced as needed. The amount of oxygenation the patient receives from the ECMO circuit depends on two main factors. First, the set FDO2, and second, the amount of blood flow going through the circuit. More liters of blood flow going through the ECMO circuit leads to the higher the proportion of the patient's cardiac output that is fully oxygenated, which leads to more systemic oxygen delivery. The amount of ventilation or carbon dioxide clearance is controlled by the sweep gas, which is the rate of gas flow through the oxygenator. The sweep gas is typically in a range of 2 to 6 liters per minute, but can range up to 10 to 15 liters per minute. Higher sweep gas flow rates will provide more carbon dioxide clearance, and lower sweep gas will do less. Next, the now oxygenated or red blood leaves the oxygenator and flows through the venous return cannula back to the right atrium. It then gets dispersed through the lungs, which are doing very little for gas exchange, and then out to the body. That is the general flow of the ECMO circuit, so let's review. Blood is drained via the venous cannula in the femoral vein, flows into the ECMO pump through negative pressure or suction, gets pushed by the pump through the oxygenator where the blood undergoes gas exchange, and then flows back through the return cannula to the right atrium and is dispersed through the lungs and out to the body by the patient's native cardiac function. Oxygenation is controlled by the FiO2 and blood flow, and carbon dioxide is controlled by the sweep gas flow rate. The last component of the VV ECMO circuit I will describe is anticoagulation. In general, exposing blood to the extracorporeal circuit activates the patient's clotting cascade and increases the risk of clot formation. If clots form in the ECMO circuit, they can impair the function of the ECMO circuit or embolize into the patient. For VV ECMO, clotting is of slightly less concern than for VA ECMO because these clots would return to the venous system. However, we still try very hard to avoid them. In order to reduce this risk of clot formation, we do a few things. 1. As long as the patient does not have any major bleeding issues, we start systemic anticoagulation via an ECMO-specific protocol. At our institution, the default anticoagulant is heparin, and we monitor anti-10A levels with a goal of 0.2 to 0.4, which can be modified as needed based on patient factors. 2. The cannulas are all heparin-coated to reduce clot formation. And 3. We typically maintain high flows in the ECMO circuit, at least 2.5 liters per minute, to prevent blood stagnation until the patient is ready to wean off of the ECMO circuit. This is especially important if a patient is unable to tolerate systemic anticoagulation due to major bleeding issues. So let's rewind. Putting someone on VV ECMO is incredibly complex. You should always work with your team to discuss if this is a viable treatment option for your patient. In general, remember there are strong contraindications like other organ failure, metastatic malignancy, severe neurological insult, and irreversible lung damage that you must consider. Also, remember that the patient's heart needs to be working well since VV ECMO provides no cardiac support. Ask yourself if your patient would receive VV ECMO as bridge to recovery or potentially as a bridge to lung transplant. If recovery is unlikely and the patient is not already listed for lung transplant, then VV ECMO support probably should not be initiated. The VV ECMO circuit typically includes 2 cannulas, one venous drainage cannula that drains the blood, and one return cannula which returns the blood to the right atrium. The blood will drain through the venous cannula into the pump and oxygenator, which provides the gas exchange, and then returns the blood to the right atrium to be delivered through the lungs and out to the body by the patient's heart. Lastly, remember that these patients should be on anticoagulation, if possible, to prevent clot formation either in the ECMO pump or cannulas. Thanks for watching and tune in to our next videos to learn more about VV ECMO.